Okay, deep dive time, and looks like we're tackling acute respiratory failure today.
Definitely a heavy hitter.
No kidding, but important stuff, right?
Absolutely, and surprisingly complex.
Right. You think lungs, oxygen, what's so hard? But
Oh, it gets complicated fast. This article we're looking at by Vosks and the team, it really digs deep.
published just this year too, so we're on the cutting edge.
Exactly, hot off the presses, and it's crucial for anyone who wants to really sound like they know their stuff.
Whether you're prepping for rounds, you've got a presentation, heck, even just for your own curiosity.
Exactly, knowledge is power, right? And this deep dive, this is your shortcut to expertise.
Love it. So, acute respiratory failure, what we were saying, sounds simple on the surface, right?
Oh,
Lungs can't do their job.
and that job is
Well, the basics. Getting that sweet, sweet oxygen into the blood and that CO2 out of there,
the old gas exchange, vital for life.
you got it. But you were saying it gets tricky fast. Why is that?
Because it's not always as simple as just the lungs not working. We've got two main types of acute respiratory failure to think about, type 1 and type 2.
Okay. And knowing the difference is important for treatment, correct?
Absolutely, it changes your whole approach. Think of it like, I don't know, needing a jump for your car versus needing a whole new engine.
Okay, I like where you're going with this. Both will leave you stranded.
Exactly. But the fix is completely different.
So with acute respiratory failure, we've got type 1, which is like your classic oxygen problem, not enough getting to the blood.
Right, like your car battery's dead, you just need a boost.
But type 2 is where things get interesting, right? That's a ventilation problem. CO2 is building up because those lungs just aren't expelling it like they should.
More like that engine problem, something's fundamentally wrong with how the system is working.
This is a good analogy, I gotta say. So how do doctors even start to figure out what's going on?
Yeah.
It's got to be more than just like listening to someone breathe, right?
You're telling me. We rely on some pretty specific measurements, looking at the gases in the blood, oxygen, and carbon dioxide.
Right, getting down to the nitty-gritty. So what are some of the tools of the trade? How do you measure this stuff?
Well, one of the big ones is the PO2/FiO2 ratio. Basically, it's comparing the oxygen level in the blood to the amount of oxygen the patient's getting.
So like how efficiently those lungs are actually pulling in the oxygen.
Precisely.
Yeah.
And this isn't just some random number. It actually helps us determine the severity of ARDS,
ARDS.
acute respiratory distress syndrome. Basically, a life-threatening lung injury that makes it really hard to breathe.
Got it. So the PO2 FiO2 ratio, the lower it is.
The worse the ARDS, like a gauge on your dashboard, the lower the reading, the closer you are to trouble.
Yikes. Definitely don't want to see that needle dipping too low. What other tools are in your arsenal?
Well, there's another index called the oxygenation index, which is even more detailed. It takes into account things like how much effort the patient is putting into breathing.
So it's not just about the oxygen levels, but also how hard those lungs are working to get it.
You've got it. It paints a much fuller picture of just how much distress the lungs are in.
Okay, so let's say we've done our detective work, diagnosed the problem, the lungs are in trouble. Time for the cavalry, right? What are we talking about for interventions?
Well, think of it like a ladder, right? You start with the simpler stuff and escalate if you need to.
I'm with you.
So, first rung on the ladder might be something as simple as supplemental oxygen, your basic oxygen mask.
Classic. We've all seen those in movies. But it's not always enough, is it? What happens when you need to climb higher on that ladder?
That's when things get really interesting. You could step up to high-flow nasal oxygen, delivers a higher concentration of oxygen at a much faster rate.
Ah, so a little more oomph than your average oxygen mask.
Exactly. Or you might even jump to non-invasive ventilation.
NIV, right?
You got it. That's where you're using a mask or similar device to help support breathing without actually having to intubate the patient.
Which is a whole other ballgame, right? Intubation, mechanical ventilation, that's the big leagues.
Absolutely. And the decision to go that route is never taken lightly. There are risks and benefits to each level of intervention.
That makes sense. You don't want to jump to the most extreme measures unless you absolutely have to.
And that's where this article really dives into some of the nuances of NIV, because while it can be a fantastic tool, it's not always the right call.
Okay, so tell me more about that. When does NIV fall short? When would it be maybe even risky to use?
Well, for one thing, timing is everything. This article really stresses the importance of recognizing NIV failure early on.
So knowing when it's just not working and you need to switch gears, what are some of those red flags?
You're looking at a few key things. First and foremost, are the patient's blood gases improving? If not, that's a big warning sign.
Right, if they're still struggling to get that oxygen in or CO2 out.
Exactly. Or if their overall condition is getting worse, obviously that's a problem. And then there are more practical considerations, like if the patient just can't tolerate the mask for whatever reason.
That makes sense. I mean, if you're already struggling to breathe, having a mask on your face probably isn't helping matters.
You got it. And on the flip side, delaying intubation if it is truly needed, that can be risky too. It's a delicate balance, weighing the potential benefits of NIV against the potential risks of delaying more aggressive interventions.
It's a tough call, no doubt. And speaking of tough calls, that brings us to a pretty serious topic when we talk about invasive ventilation. Ventilator-induced lung injury, or VILI.
Yeah, that's the irony, isn't it? The very treatment that's supposed to help the lungs can sometimes cause more harm.
How does that even happen? I mean, it just seems counterintuitive.
It's a constant challenge in critical care, finding that sweet spot between providing life-saving support and minimizing the risks of that very support.
A delicate dance,
Yeah,
for sure.
yeah.
But in terms of VUL, what's actually causing the damage?
Well, it's multifactorial, but the article breaks it down into a few key mechanisms. One is barotrauma, which is essentially damage from too much pressure in the lungs.
Okay, so you're saying, like, too much pressure over time can actually injure those delicate lung tissues.
Exactly. And then there's volutrauma, which is damage caused by overdistension of the lungs. Think of it like stretching a rubber band too far.
Eventually, it just loses its elasticity.
Precisely. And then there's another type of damage called atelectotrauma, which is a bit more complex. It's basically
It's those tiny air sacs in the lungs collapsing, right? Like little deflated balloons.
you're on top of it, and that can really hinder oxygen exchange. So you've got these three main culprits: pressure, volume, and this repetitive opening and closing of those air sacs.
And all of that can contribute to VILI. But can you even tell that apart from the original lung injury? I mean, how do you know what's causing what?
That's the million-dollar question, and unfortunately, there's often no easy answer.
So you might not even be able to say for sure if it's VILI or something else.
Sometimes it's just impossible to distinguish VILI from ARDS caused by other factors. The symptoms can be very similar, even how it looks on imaging.
So how do you prevent something that you can't even clearly diagnose? That's got to be a tough one.
It is. But while we can't always definitively diagnose VILI, we do know the risk factors, and that's where lung protective ventilation strategies come into play.
Lung protective strategies. Tell me more about that. What does that actually mean in practice?
It's all about minimizing those risk factors we were just talking about, so careful adjustments to the ventilator settings are crucial.
Okay, so being really mindful of the pressure and volume being delivered with each breath.
Exactly. For example, using a lower tidal volume, that's the amount of air delivered with each breath, that can make a big difference.
And maintaining a lower plateau pressure, right? That's the pressure at the end of each breath.
You got it. It's all about finding that sweet spot, enough support to help the lungs heal, but not so much that you're causing more harm. And then there's PEEP, positive end expiratory pressure.
PEEP? I've heard of that. What's that all about?
Think of it like keeping those tiny air sacs open, like blowing up a balloon and then keeping a little bit of air in it even after you let go. That's PEEP.
Ah, okay. So it helps prevent those air sacs from collapsing completely.
Exactly. But of course, too much of a good thing can be bad. Too much PEEP can actually overdistend the lungs, leading to more problems.
So it's all about finding that balance, as always. But this whole area, VLI, lung protective ventilation, this feels like it's constantly evolving. Are there any new concepts on the horizon?
Absolutely. And this article touches on one that's gaining traction: ergotrauma.
Ergotrauma, okay. I'll admit I'm not familiar with that one. Break it down for me. What is ergotrauma?
Well, think about it. Every breath takes energy, right? Whether it's the patient doing the work or the ventilator.
Okay, that makes sense. So what does that have to do with lung injury?
Ergotrauma is the idea that too much energy over time can actually injure the lungs. So it's not just about the pressure or volume of each breath, it's the total energy load that matters.
So even if those individual breaths seem okay in terms of pressure and volume, if there are just too many of them, or if the effort is too high, that can still be a problem.
Exactly. It's a relatively new concept, but it has some interesting implications for how we think about lung protective ventilation.
That is fascinating.
Yeah.
It really makes you wonder if there are other ways to support healing beyond just adjusting the ventilator settings. Like, are there other interventions that could help reduce that energy load on the lungs?
You're thinking like a true innovator, and while that's a bit beyond the scope of this particular article, there are some other fascinating interventions that go beyond the ventilator itself.
Okay, now you've got my attention. I love when things get a little unorthodox. What kind of interventions are we talking about?
Well, one that might surprise you is prone positioning.
Prone positioning. You're saying, like, just changing the patient's position can actually make a difference.
It sounds almost too simple, right? But especially in severe ARDS, it can be surprisingly effective.
I'm intrigued. Tell me more.
So think about it. When a patient is lying flat on their back, gravity is working against them.
Okay, I see where you're going with this.
Their heart, their other organs, it's all pushing down on those lungs, making it even harder for them to expand and do their job.
So flipping them onto their stomach, you're basically using gravity to your advantage.
Bingo! It helps open up the airways, improves blood flow to areas that might be struggling.
Wow, I never would have thought of that.
And the research backs it up. This article mentions studies where prone positioning actually led to better oxygen levels, even helped some patients avoid needing a ventilator altogether.
Okay, color me impressed. I got to admit, I underestimated the power of a good flip. But let's say, we're in a critical situation. We've tried all the usual suspects. Nothing seems to be working. What's our Hail Mary?
Well, that's when you might have to consider what we call extracorporeal therapies, treatments that happen outside the body.
Okay, now we're talking serious medical firepower. What kind of options are on the table at that point?
This article focuses on two main types. There's extracorporeal carbon dioxide removal, which does exactly what it sounds like. It removes CO2 from the blood.
Sounds pretty handy.
It can be a lifesaver. And then there's the big one, ECMO, venovenous, ECMO to be precise.
ECMO, that's the one you hear whispered about in hospitals, right? The ultimate life support.
It's about as close as we can get to an artificial lung.
Okay, so walk me through this.
Basically, with ECMO, you're taking the blood out of the body, oxygenating it, removing the CO2, and then pumping it back in, all with this external machine.
Wow, so it's literally doing the work of the lungs.
Exactly, giving those lungs a chance to rest and recover.
That is wild. But I have to imagine, as with anything this powerful, it's not without its risks.
You're right to be cautious. ECMO is a big decision, not something you jump into lightly.
Definitely not a first-line therapy.
Right. The article really stresses that it's reserved for the most severe cases, and even then, only when there's still a reasonable chance that the lungs can recover.
So a lot of factors to consider, a lot of tough decisions.
And that's where those case studies at the end of this article are so helpful. Seeing how these interventions play out in real patients with all their complexities, it really brings it home.
You know me, I'm always a sucker for a good case study. It's like putting all this knowledge into practice.
Absolutely. And this article has some great ones.
All right, well, we've covered a ton of ground today, from the basics of acute respiratory failure all the way to ECMO. It's been quite a journey.
And a crucial one, acute respiratory failure. It's something that every clinician, really anyone in healthcare, needs to understand.
Absolutely. So for those listening, whether you're prepping for a challenging case or just satisfying that endless medical curiosity, consider this your crash course in all things acute respiratory failure.
And remember, knowledge is power. The more you know about this complex condition, the better equipped you'll be to provide the best possible care.
Couldn't have said it better myself. Well, on that note, we'll wrap up this deep dive. Until next time, stay curious, stay informed, and most importantly, stay healthy.